Hello and welcome everyone to this session on Mission FMGE Short Subject Revision in Dermatology Part 1. So I hope you guys can see me and hear me well. Alright, so I know many of you all have been attending my Mission FMGE revision sessions for medicine. So now this time I have also started along with medicine for short subjects. So we just want to finish all our subjects quickly, start revising them. So already we have finished in medicine many systems. Today, okay, I'll just tell you because there are so many classes. I just want to inform you guys before we begin the class that at 3 p.m. we have Dermat Part 1, which we are doing now. At 5 p.m. we'll be having Dermat Part 2. Okay. So many of you all are asking me why, ma'am, Dermat Part 1, Part 2, why can't you take a continuous 2-hour lecture? Because many people get bored in 2-hour lectures. So that's why I've split it up into 2 parts. Okay. And then at 8 p.m. today on YouTube, we will be having Dermat, at 8 p.m. on YouTube, we will be having endocrine. Okay. So this is our Mission FMG medicine revision. So we'll be having endocrinology revision at 8 p.m. tonight. Okay. Now moving on with the subjects. If you guys know, I have made one pamphlet. So today we are going to be completing whole of dermat. Tomorrow we are going to be completing whole of anesthesia. So tomorrow 7 o'clock and 8 o'clock we will be having anesthesia class. After that, day after tomorrow we will be doing orthopedics. Friday we have a holiday. On Saturday we will be doing radiology, and on Sunday we will be doing psychiatry. Okay, so in 1 week you will be able to complete all the short subjects revision as a part of FMG. Now this is also useful for those who are giving INI, CET, NEET PG, all those exams also. So let's begin with our class for today. Welcome to Unacademy. You can learn from India's top educators here. The iconic subscription between PrepLadder and Unacademy will give you the best of both. The NEET PG combat test has already happened. You guys can give the INI CET mock test. These are our special class features. We have a nice question bank, and these are all our toppers. We have the clinical case discussions instrument batch, target NEET PG 2022 batch, and next integrated batch 2023 that is available. And if any of y'all would like to join the plus subscription, you can use my code Dr.Jhanvi Light, which will give you 10% off on your subscription. Okay. So let's begin with our class for today. What we will be discussing today. So Dr. Kamal is asking, ma'am, what about neurology and hematology? So before I begin, should I tell you guys the whole timetable? Because every day I have at least 10 people messaging me, ma'am, when will you take this? When will you take that? Okay. Okay. So फटाफट से I will tell you the whole timetable that we have. Now I told you we are going to do short subject revision in 1 week. Correct? So for this, today I'm going to be doing dermat for you guys. The second class of dermat is at 4 o'clock. And then at 8 p.m. today, we are going to be having endocrine class on YouTube. Okay. After that, at tomorrow, that is on 20th, we have revision of anesthesia in 2 hours. On 21st, we have revision of orthopedics in 2 hours. Then on 22nd, we don't have anything. On 23rd, we have revision of radiology in 2 hours. And on 24th, we will be having revision of psychiatry in 2 hours. Okay. So these are all the classes that I have planned for you guys. Now, after this, 24th is a Sunday. So 25th onwards, 25th, 26th, 27th and 28th, we will be doing the rest of medicine that is left. Today, we are going to do endocrine. But then on 25th, we are going to be doing hematology. On 27th, we have respiratory system, and on 27th, we have neurology, and on 28th, we will be doing miscellaneous. Okay, so like all the instruments, tests and medicine, all of that. So we'll be completing the whole of medicine also. So don't worry, at the end of this month, you will be done with everything. So let's begin with our class for today so that we are able to finish off our portion. So can you, first question for you guys, name the layers of the epidermis from outside to inside. So very, very basic thing for you guys. So I'm going to start the poll for you, and I'm going to give you 30 seconds to answer in the poll. You guys can answer quickly. Tell me the layers of epidermis from inside to outside. This is going to be an interactive lecture. I will expect you guys to answer questions also, so that I know that you guys are studying and revising the subject. Okay. All right. Very good. So most of you have answered this absolutely correctly. So stratum corneum, granulosum, spinosum, basale. Now, can you guys tell me how to remember this? I always remember it as one thing. Okay, so corn gravy, spicy or bland? How do you like your corn gravy? You like it spicy or you like it bland? So corn gravy, spicy or bland? Corneum, granulosum, spinosum and basale. So that is my favorite way of remembering this. Now, is there any layer over here that I'm missing? Anyone? Any extra layer that is present in the palms and soles, and what is the name of the layer? Absolutely correct. That there is stratum lucidum which is present in the palms and soles. Okay, so the first question that they will ask you is which is the thickest layer of the epidermis? And the options will be stratum corneum, granulosum, spinosum, basale. What is the thickest layer of the epidermis? Very good. So the thickest layer of the epidermis is stratum spinosum. Okay, what is the dead layer of the epidermis? Okay, little better handwriting. Okay, I'll do that. Then give me 10 seconds to write properly, because if I write slowly only, then the handwriting will come nice. Okay, yes, the dead layer of the epidermis is stratum corneum. Now let's do individual layers and what are the questions asked about it. So can you tell me what are the basic layers of the skin from outside to inside? What are the basic layers of the skin? Don't tell me the layers of the epidermis. I'm asking you the layers of the skin. Very good. Absolutely correct. So it is epidermis outside, then it is dermis, and then it is hypodermis. Absolutely correct. Okay. What is the principal cell in the epidermis? If they ask you out of all the layers of the epidermis, which is the main cell that is present? Very good. It is keratinocytes. Now, what do these keratinocytes do? These keratinocytes actually are generated over here at the level of the stratum basale. And as the days goes by, these keratinocytes will start moving up. And finally, they will come up to here till the stratum corneum and they will get shed from here. Correct? Absolutely correct. Okay. So the keratinocytes are the main cells that are present in the epidermis. Okay. What is the type of epithelium in the epidermis? Anyone? What is the type of epithelium in the epidermis if it is asked? Is it squamous? Is it columnar? Yes, very good. It is stratified squamous epithelium. Okay. Now tell me, what is the other name of stratum corneum? Stratum corneum is also called as, we have already discussed this, it is called as the dead cell layer because it contains most of the keratinocytes, correct? Okay, so what is the name of the condition in which there is thickening of the stratum corneum? If you have thickening of the stratum corneum, increase in the number of keratinocytes over there, what is that known as? Is it hyperkeratosis or is it parakeratosis? Or is it psoriasis? Yes, absolutely correct. Thickening of the stratum corneum is called as hyperkeratosis. Why? You have increase in the number of keratinocytes that are present at the level of the stratum corneum. So you have hyperplasia of the cells. So that is why this is called as hyperkeratosis. Okay. All right. Now, what happens if there is retention of nuclei by cells of the stratum corneum? So usually when you have the keratinocytes coming up from stratum basale up to stratum corneum, when they go up, they start losing this nucleus that is present. Okay. So at the top layer at the corneum, they do not have that nucleus usually. But if they happen to retain the nuclei, then what do you call this condition? This condition is called as parakeratosis. Okay. So these are the few questions that they ask about stratum corneum in the exam. You should be knowing these terms. Okay. All right. Now next one is about the stratum granulosum. Like I told you, stratum spinosum was the thickest layer. Okay. This was the thickest layer. So the thinnest layer is the stratum granulosum. And what do you call it when the stratum granulosum becomes even more thicker, when there is hyperplasia of the cells of the stratum granulosum? What is that called as? Like you had hyperkeratosis in stratum corneum. What is this called? Very good, Sky. So that is called as hypergranulosis. Okay. And any special features that are present in stratum granulosum? Do you find any different kind of bodies that are present or any new protein that is present? Absolutely correct. So why do you call it a stratum granulosum? Because there is something which makes that layer as very granular. And what are these granules? These are granules of keratohyaline protein. Okay. These are granules of keratohyalin protein. So that is what makes it granular in nature. Now the second thing that is present over here starts with an O. Anyone knows O? Yes, as Dr. AJ has correctly said, these keratohyalin granules are made up of filaggrin protein. O से क्या होता है? Why am I marking all this for you? Because they can ask you, keratohyalin granules are found in which layer of the epidermis? O-gland bodies are found in which layer of the epidermis? So you should be knowing that, okay? Next one is stratum spinosum. Now, can anyone tell me why stratum spinosum is called stratum spinosum? What is the extra presence that makes it stratum spinosum? And what is the other name of stratum spinosum? Yes, absolutely correct, Monish. So the other name of stratum spinosum is prickle cell layer. Okay. Now, why is it called prickle cell layer? Whatever other cells that are present in the stratum spinosum, they are connected to each other by presence of these spines. Okay, spinous processes, and these spinous processes are called nothing but desmosomes. Okay. So because these spinous processes make it look like a prickle, like a prickly thing, like a porcupine, that's why it is called as the prickle cell layer. So the special features of stratum spinosum is desmosomes. Okay. What is the thickening of stratum spinosum called as? Anyone? Like thickening of stratum corneum is called hyperkeratosis. Thickening of stratum granulosum is called hypergranulosis. Thickening of stratum spinosum exactly is called as acanthosis. Okay. All right. Now the last question. What is stratum malpighi? Which two layers together form the stratum malpighi? Very good, Dr. AJ. So stratum malpighi is nothing but stratum basale plus stratum spinosum. Okay. Can anyone tell me about any important disease that happens because of in the stratum spinosum? Any important dermatological disease that is based in stratum spinosum? Yes, acanthosis causes what? Pemphigus, absolutely correct. So we'll be discussing that ahead. All right, okay. And the last thing I want to ask you is about stratum basale. What is the other name of stratum basale? What is it is made up of, and what are the special cells that are found over here? Okay, now you need to know in stratum basale, the epithelium is different as compared to the rest of the epithelium. Okay, so initially we had stratified squamous epithelium that was the main part of the epidermis. What is the epithelium that is present in stratum basale? What kind of cells are present in stratum basale? Very good. So you have columnar cells that are present in stratum basale. It's not stratified squamous epithelium, it is columnar cells that are present here. What is the other name of stratum basale? Nothing. It is also simply called as basal cell layer. Okay. And what are the special cells that are found over here? So someone has mentioned very nicely, Stuffy has mentioned over here, they are melanocytes. Okay. So what there is melanocytes, one is for pigmentation, correct? And can you tell me if there is one more receptor that is present over here in the stratum basale? Very good, Krishna. So you have Merkel cells, okay? Merkel cells that are also present. Now these Merkel cells are nothing but are touch receptors. And the third thing, as Dr. Tariq has correctly mentioned, is also keratinocytes. Now remember, keratinocytes are present in all the layers of the epidermis as it goes down from basale to up to the corneum, okay? But they will be maximum in the corneum, okay? Now, where do you find stratum lucidum? In between which two layers, and where in the body do you find stratum lucidum? Yes, very good. So stratum lucidum is found in the palms and soles. And in between which two layers do you find them? You will find them here, just below the stratum corneum. Okay. So can you see over here? This is the stratum corneum that they've given over here, the whole thing. And then you're seeing this thin stratum lucidum that is present over here between the corneum and granulosum. Okay. So is this handwriting okay for you guys, or should I improve my handwriting? I think I should sit the whole day and do some handwriting practice. रात को मेरा पेट बहुत दुखता है, I think, because all of you give me a lot of galis for writing such bad handwriting. Okay, all right. Now, next layer that we have, so we discussed the first layer we had was epidermis, okay? And the second layer that we have is dermis. So, tell me this. No, Odland bodies are present in granulosum. They are not present in the spinosum. They are present in granulosum, keratohyalin granules and Odland bodies. Okay. Yes, absolutely correct. So what are the two types of dermis that we have? So the two types of dermis that we have are papillary dermis and reticular dermis. So can you tell me collagen is present in abundance in which dermis? Papillary or reticular? Collagen is the main component for which dermis? Absolutely correct. So collagen is present in abundance in the reticular dermis. Okay. Now last layer that we have below the dermis is the hypodermis. So the question that will come in the exam, one liner. Hypodermis is thickest in this part and it is the thinnest in this part. So hypodermis is thickest in which part and it is thinnest in which part? In which part of the body is the hypodermis thickest? In which part of the body is the hypodermis thinnest? Batao, anyone or no idea? If you have no idea, then I will answer the question. Okay, so hypodermis is the thickest in the palms and soles. Okay, and now can you tell me where is hypodermis the thinnest in? Very good, Tariq. So it is the thinnest in the eyelid. Okay, all right. Now let's see the one-liner questions that they ask about the cells of the epidermis. So keratinocytes, they will mainly ask you, where are the keratinocytes exactly present? Okay, the maximum amount of keratinocytes, they are present in the stratum corneum. Okay, then next they will ask you, where are desmosomes present? So which layer are desmosomes present in? Spinosum, that we have already seen, correct? Okay, in which layer are melanocytes present in? In stratum basale. Okay, now what are Langerhans cells and which layer are they present in? Or many times they ask antigen presenting cells of the skin are also called as Langerhans cell. Okay, yes, and these Langerhans cells are present in stratum spinosum, correct? Okay, now the next thing that they will ask you is what type of cells are Langerhans cells. So antigen presenting cells are what? Which part of the immunity do they belong to? They are nothing but macrophages. Okay, and then we have Merkel cells. Merkel cells are nothing but touch receptors derived from the neural crest. Okay, and these touch receptors are also present in stratum basale. Okay, absolutely correct. What is the other cell that is present in stratum basale that we saw? So spinosum has Langerhans cells, basale has Merkel cells, M and M, Merkel cells and melanocytes. Okay. All right, now let's go on to the glands of the skin and their diseases. So you have two types of the glands of the skin. You have eccrine glands and you have apocrine glands. So first question they will ask you is, what is the location of the eccrine glands? What is the location of the apocrine glands? So first tell me, what is the location of the apocrine glands? Anyone? These apocrine glands are nothing but specialized sweat glands, correct? So if they are specialized, they must be present in some special areas. They are not present everywhere. So where exactly are they present? Very good. So your apocrine glands are present mainly in the axilla and the groin and umbilicus and the areola of the breast. Okay, so this is where all your apocrine glands are present. What is the location of your eccrine glands? Anyone? Eccrine glands location? They are diffuse, they are present all over the body. So except these areas of apocrine glands, everywhere else you will have the eccrine glands because they are basically forming the sweat glands of the body. Okay, now what is the nervous system control of eccrine glands and nervous system control of apocrine glands? So which is under sympathetic nervous system, which is under parasympathetic nervous system? Yes, so you know that the parasympathetic nervous system is the one that maintains the body. Okay, so there will be cholinergic control of the glands which are present in majority part of the body. So your eccrine glands are under cholinergic control. So then your apocrine glands will be under what control? They are under adrenergic control. Okay, all right, so that is why whenever you are scared, whenever you are panicking, you start sweating, your axilla starts sweating. Have you ever felt that? You will feel very sweaty in your axilla. That's because you have increased sympathetic system discharge and that is causing the apocrine glands in the axilla to start sweating. Okay, so that's how you remember it. Normally when you're sweating, the cholinergic system is taking into charge and it is causing sweating in the eccrine glands of the body. Okay, So what is the function of both these glands? The function is sweating. Now the most important part is what is the pathology of both these glands. So what are the diseases of the eccrine glands called, and what are the diseases of the apocrine gland called? Okay, so I'll show you some pictures. You tell me whether it is eccrine gland or apocrine gland problem. So this is Miliaria rubra. Have you heard of this? This is called as Ghamoria. There is one nice ad. Chupti jalti garmi ka mausam aaya, Ghamoria laya. What is that? Nycil. Absolutely correct. So this is that Ghamoria. This is Nycil wala Ghamoria. Okay, so this is Miliaria rubra. So Miliaria rubra mein, can you tell me what is the gland that is affected? So that is the question that they will give. They'll give you a question of a 17, 18-year-old or a small child, like 10-year-old, who is going out to play during the summer season, and he comes with this appearance of the gland, this appearance in front of his chest and behind his chest, and it is a little itchy also. So this is Miliaria rubra, that is caused due to the overactivity and occlusion of eccrine glands. Okay, so eccrine sweat glands are affected in this. Okay, next is Fox-Fordyceus disease. So now tell me, is this a pathological disease? The first question, listen to it. Is this a pathological disease or is it a normally occurring thing? Is it a pathological disease or is it a normally occurring thing? Stuffy is saying it's normal, Krishna is saying it's pathological, and Sky is saying it's apocrine. Uska kuch alag hi funda hai. Okay, so this is a pathological disease as compared to Fordyceus spots. If you see Fordyceus spots, is this physiological or is it pathological? Is it normal or is it pathological? Yes. No, Fordyceus spots are not pathological. Your Fordyceus spots are normal. Okay, your Fordyceus spots, they are not saying disease over here. So if they are saying disease, that means it is abnormal. Okay, so this is nothing but presence of ectopic sebaceous glands. So these are, first of all, not sweat glands. Your Fordyceus spots are sebaceous glands. Okay, and these are sebaceous glands that are not present in the normal place, but there is no problem in them. So they are present here on the upper vermilion line. So these are ectopic sebaceous glands. Okay, so how will you remember this? Either disease nahi likha hai, so that means it is normal. Okay, now if you look over here, Fox-Fordyceus disease likha hai, so this has to be pathological. So what are the glands that are present in the axilla and the groin? I told you there are apocrine glands. Okay, so when my apocrine glands get obstructed, that is when I get the sweat out of it will not flow and the glands will become hypertrophied and look like this. So this is a problem, correct? The duct is getting obstructed. So this is my Fox-Fordyceus disease. Clear? So this is a problem of the apocrine sweat glands, and Fordyceus spots is sebaceous glands. Okay. Now tell me, what is the function of the sebaceous glands and what is the disease of the sebaceous glands? So already one disease of the sebaceous glands I have told you. One is Fordyceus disease, and what is the other disease? Acne. Absolutely correct. Okay, so sebaceous glands function is nothing but to produce sebum. Sebum is like a lubricating agent present for the hair. Okay, all right, so Fordyceus spots dekh liya. So the next thing that we will discuss is acne. Now acne is a disorder of pilosebaceous glands. Now you'll ask, ma'am, what is pilosebaceous glands? So we already know what is sebaceous gland. Sebaceous gland is the gland which produces sebum. Okay, now this sebum, this sebaceous gland is attached to a follicle of hair over here. So this sebum will go, and this is the top of the skin, and the hair will come out from here. And if you see the sebum, this will be secreted over here to lubricate this hair. Okay. Now tell me, what happens if I have an obstruction of this sebaceous gland at this level? Inside, if the sebaceous gland gets blocked, then what do I call it? Is it called white comedone, or is it, sorry, is it called as open comedone, or is it called as closed comedone? Open comedone or closed comedone, and white head or black head? Absolutely correct. So if there is obstruction of the sebaceous gland inside the layer of the skin, okay, so this is called as a white head. Many of you all must be having, go and look in the mirror, you all must be having on your nose white heads. Okay, And finally, those whiteheads will turn into blackheads and then into pimples. Okay, so this is whitehead, or it is also called as closed comedone. And if the obstruction is at the level of the skin and you have some dust particle or something which has settled over there, then this is called as blackhead or closed comedone. Oh, sorry, open comedone, because it is open to the surroundings. So there is a keratin layer which gets congregated and it comes over here and gets spread over here. Okay, yes. So what happens once this comedone is caused? If there is an obstruction, the sebaceous gland goes on increasing in size. Okay, once it increases in size, this will get secondarily infected. So when this gets infected, what is the organism that is responsible for this infection? What is the causative organism of acne? Is it staph or is it propionibacterium? Absolutely correct. It is propionibacterium. Okay. So that is why it's very important for you. They keep saying na, aapko, if you have any kind of boil or any beginning of acne, don't touch it. Why? Because from your hands you are going to transfer the propionibacterium and make it grow more and more. Okay. So that is the reason. Okay. After that, the next question that they ask, Vignesh is asking, why not staph, man? You ask Staphylococcus why it is not able to produce inflammation of the sebaceous gland. Don't ask me. Okay, then the next thing is, this is acne vulgaris. Okay, so you have acne vulgaris and you have acne conglobata. So these are the two types of disorders you should be able to identify in your exam. Now you have to tell me what type is more severe, acne vulgaris or acne conglobata. I think this is more obvious from the pictures only. Absolutely correct. So your acne conglobata is the most severe form of acne. What is the other name of acne conglobata? Yes, it is also called as nodulocystic acne. Nodulocystic acne. Okay. All right. Anyone, can you tell me what are the drugs used for the treatment of acne? Because that is the next slide. That's why I want to ask you, what are the drugs used for the treatment of acne? Okay, so isotretinoin, one thing. Okay, when do you avoid retinoids? If they ask you, this patient is planning to get pregnant in the next 2 months, so will you give them retinoids or no? Yes. So if a pregnancy is being planned, then you will avoid isotretinoin or retinoids. Okay, it is teratogenic. Second, antibiotics mein clindamycin, very good. What else? Doxycycline, good. Anything else? Ivermectin, okay. All right. So let me show you all the drugs that you give for acne. Now I have noted it down over here because I didn't want to sit and write all of them, but I wanted them to be available for you all. Okay. So for topical therapy, you will use benzoyl peroxide gel or erythromycin gel. Erythromycin will take care of the propionibacterium. Benzoyl peroxide will help in breaking up the comedone. So that obstruction that is causing the formation of the comedones, it will help in breaking up that obstruction. Okay. Then other agents, comedolytics like retinoic acid, adapalene, antibiotics like erythromycin, clindamycin, intralesional steroids, especially when you have this nodulocystic acne, you can give steroids to reduce the inflammation of the gland. Okay. Systemic antibiotics and systemic anti-androgens. So these are all our treatments for acne. Okay. Now question for you guys. Which of these drugs causes acne? INH, rifampicin, oral and topical steroids, anabolic steroids, or all of the above? Causative for acne. Read the drugs carefully. Some of them could be treatment also. Okay, very good. So all of the above drugs are responsible for causing acne. So your INH, rifampicin, anabolic steroids, oral topical steroids, all of them are responsible for causing acne. They can ask you this in the exam, causative drugs for acne. Okay. Now moving from acne to pigmentation disorders. So this is the first question. Identify this pigmentation disorder. This is a 3-year-old child. He is coming with his mother. The mother is saying he had a small birthmark that was present over here and now it has grown very big, so she is very scared. So what is the advice and what is the diagnosis you will give her? Pityriasis rosea, alba, versicolor or P. baldism? Okay, very good. Most of you have answered this correctly. So rosea will be nothing but an erythematous patch. Alba means white. Okay. Have you seen Jessica Alba? There is one very nice model called Jessica Alba. Okay. So have you seen how white she is? So that's how you can remember. Alba means white. Okay. Or albinism also means white. So what is happening over here? First of all, the question is this a hypopigmented lesion or is this a depigmented lesion? Hypopigmented or depigmented lesion? Yes, there is hypopigmentation. Okay, how do you identify it? If you see the borders of this patch, they are merging with the rest of this normal skin. Okay, so that means the lesion is hypopigmented. There is some amount of melanin that is produced, but it is not that there is no melanin that is produced. Okay, now so this is your Pityriasis alba. So generally it happens since childhood. The parents will come to you saying that the birthmark is enlarging in nature. So what will your treatment be for this? Any treatment do you have for this? Any treatment that you guys have for this? Okay, there are a couple of treatments that maybe they'll ask you in your exam. One is PUVA therapy, Soralin UVA therapy. So you give the Soralin drug and then expose to ultraviolet rays. Okay, and the second thing that you can give is tacrolimus. But the most important treatment is self-reassurance. Okay, you have to reassure the parents that this is okay, it is normal, it will grow in size, but at one point in adulthood, yes, during puberty, it will stop growing. Okay, so it will be only that much. I'm sure you guys must have seen patients like this before. All right. Next pigmentation disorder, identify Pityriasis rosea, Pityriasis alba, vitiligo or P. baldism. Now, this is a model who has come to you and she's saying that doctor, initially I had this lesion only on this side. Now I also have it on this side. And since the past 3-4 months, it has come here also. So she is very worried. Should she be worried or should she not be worried about it? Okay, Stuffy is saying she should be worried about it. Why? Because she's a model, is it? Absolutely correct. So this lesion, as you can see over here, you saw this hypopigmented lesion. So the margins of this lesion was merging with the rest of the skin. But here you can see very nicely, sharply demarcated margins. Okay, so why is this happening? Because this area, the melanocytes are not producing any melanin at all. There is zero melanin present over here. So this is vitiligo. Now, can you tell me why the melanocytes are not producing melanin? Is there any specific reason for that? Any specific reason for the melanocytes not producing melanin? Very good. So it is an autoimmune destruction of melanocytes. Okay. So there is autoimmune destruction of melanocytes. Now tell me, why should I be worried about this lesion? If this patient comes to me, why should I be worried about it? Because there may be other autoimmune disorders also that are related to this patient. Okay, so in fact there are many disorders, especially you have Hashimoto's thyroiditis, then you have your yes, you have type 1 diabetes mellitus. All of these are associated with it. Addison's disease. So you should be checking the patient for these other diseases and symptoms also. Okay, what will be the treatment for this if it is an autoimmune disorder? What is the only treatment that we have? PUVA, okay, not much. Yes, so corticosteroids and immunosuppressants. These are the mainstay of our therapy for vitiligo. Okay, so I'm writing over here corticosteroids, and she'll have to be on long-term steroid therapy. That will make her fat also. Okay, so modeling becomes even more difficult. And immunosuppressants. All right, next one. Identify this pigmentation disorder. Pityriasis rosea, acanthosis nigricans, vitiligo or melasma. Vignesh, the best way to differentiate between albinism and vitiligo is the history that the patient is giving you. Okay, so if he is telling you that someone in his family is also having the same disorder, then you can go for more for albinism as compared to vitiligo. Also, the lesions that you see in vitiligo are present in certain places. So you have acrofacial vitiligo, you will be having it at the peripheries and the face, okay, and the rest of the lesions that you have of albinism, it will be overall all over the body. Okay, okay, so 67% of you have answered this correctly. This is melasma. So now can you tell me what kind of pigmentation disorder is melasma? What kind of pigmentation disorder is melasma? Is it hyper or is it hypopigmentation disorder, or is it depigmentation disorder? Very good. So here many of you all were thinking that this is the hypopigmented part, but it's not. Just I will mark for you guys what is the hyperpigmented part. So it's like this, over her cheeks, over her nose. And what is this called as? This area distribution is called as malar area distribution, correct? So there is malar area distribution of the hyperpigmented lesion. Okay. Now this is called as melasma. Can you tell me if melasma happens to people during pregnancy also normally? So the causes for melasma are pregnancy, then you have OC pills, then you have steroids. Okay. Now, can you tell me what is it called specifically in pregnancy? If they give you this question in the exam, they give you this photo, and yes, so it is called as cloasma of pregnancy. Okay, this is called as cloasma of pregnancy. Absolutely correct. Okay, what is the treatment for melasma? Anyone? Photo protection, yes. Skin lightening agent. Okay, can you tell me which kind of skin lightening agent will you give? Sunscreen. Okay. Hey, you guys are more of cosmetologists than dermatologists, huh? सब लोग ऐसे ऐसे बात कर रहे हैं. Ma'am put sunscreen, ma'am put skin lightening agents. Okay, so glycolic acid peels. Glycolic acid and salicylic acid will help in peeling away the hyperpigmented layer of the skin. Okay, so that is called as chemical peel. And the second one is vitamin C. Vitamin C is supposed to be a skin brightening agent. Okay, so these agents are supposed to help. And of course, as you guys said, protection from sun. Okay, so photo protection or protection from sun by using a sunscreen. Okay, all right. Now don't start asking me how much SPF of sunscreen. All right. Okay, so identify the pigmentation disorder in this case: Pityriasis versicolor, acanthosis nigricans, P. baldism, or melasma. ये तो अभी बहुत easy हो गया because the options that I've given you are very easy. Okay, so most of you have answered this correctly, so we can stop the poll over here. So this is presence of white forelock of hair. You just have a bunch of white hair that is present since birth. Okay, so and this hair is present on the front of the forehead. So this is also called as the white forelock of hair. White forelock of hair. Okay. And this is present in which disease? It is present in P. baldism. So now can you guys tell me what is the treatment for this P. baldism? Is this going to increase? Is it going to decrease? Any problems with that? It is a self-limiting thing. This forelock is going to just remain like that for the rest of the life. More of hair is not going to turn white. Okay. So you have to just tell the patient and the parent especially that there is no need to worry. It will remain the same. Okay. All right. Now identify this pigmentation disorder: Pityriasis versicolor, Pityriasis alba, P. baldism, or melasma. This is very easy, but this is one of the questions that is asked maximum number of times in the exam. They love asking about this disease. So you should be able to identify it. So as you guys are answering only, I'll start discussing with you so that we don't waste time. First of all, the thing is you should see exactly where is the location of the lesion. So most of this location is either in the front of the chest or on the back. Okay. Now this lesion has feathery margins. Yes, so they have feathery margins and it has many scales on it. Okay, so the scales that are present on it are called specifically as rice powder like scales. Have you all seen rice powder? Basically, if you have not seen rice powder, it is little bit of a thicker powder. Okay, not ekdam thin powder that you put on your body, but little thicker powder. Okay, so this has rice powder like scales. The second thing that they ask is, now tell me the name of this sign. If I keep rubbing my nail on the scales and the scales keep coming out, then what is that sign called as? When I rub my nails on the scales and the scales come out, what is it called? It is called as Coupe de Onlay sign. No, Auspit sign is not present in this disease. It is called as Coupe de Onlay sign. Okay. After that, Coupe de Onlay sign. After that, the next question that they ask is, what is the causative organism? So causative organism, as many of you all have already mentioned, is Malassezia furfur. Rice की तरह होता है Malassezia furfur. Okay. All right. The next question that they ask is, what is the other name of this disease other than Malassezia furfur का other name क्या है? If I say it is Pityrosporum ovale. Okay. So sometimes in your exam they might not give you Malassezia furfur as the option. They might give Pityrosporum ovale. So you should also know that as the option. Okay. All right. Now second is, when you look at this organism on 10% KOH mount, what is the appearance of the organism? Yes, so it looks like this. It looks like big globes and then small noodles coming out of it. Okay, so the noodles is nothing but spaghetti and the big globes look like meatball. Okay, so it has a spaghetti and meatball appearance. Okay, next very famous question that comes from this is, on under Wood's lamp, what is the color of this lesion? Yellow fluorescence or apple green fluorescence? I think it is apple green fluorescence. Just confirm it once. Okay, so I think it is apple green fluorescence that you see under Wood's lamp in case of Malassezia furfur. Okay, anyone, what is the treatment of this disease? Treatment? Yes, so this is a fungal disease. It's a fungal disorder, so you have to give antifungals. Most commonly used antifungal is ketoconazole. Okay, all right. So this is one of the most important pigmentation disorders that they ask, because they have so many questions to ask about it, and these are all the questions that I've written over here that they ask about it. So you should be knowing everything about it. Okay. Next, identify this pigmentation disorder: cloasma, tuberous sclerosis, acanthosis nigricans, or melasma. Yes, so most of you have answered it correctly. So we can go ahead with the discussion. So first thing you should see, where is it present? This is a hyperpigmentation disorder present on the folds of the skin. Okay, so it will be present in the axilla, groin, neck folds. What is the other thing that you can clearly see in this child? That this child is obese. Okay, so people who are obese, who are diabetic, who have Cushing syndrome, these are the ones who will be having acanthosis nigricans. Okay. Now under the microscope, if you look at, yes, PCOD, very good. Under the microscope, if you look at acanthosis nigricans lesion, you take a biopsy of the lesion and you will see small papillomas that are present. Okay. And the question that they will ask about acanthosis nigricans is, what is the cancer associated with this disease? First question that they ask is, what are the diseases associated with acanthosis nigricans? So obesity, diabetes, Cushing's, PCOD, all of the diseases which make you fat. Okay. Second question that they ask is, cancer associated with acanthosis. So that is your gastric adenocarcinoma. Okay. Maximum chances of gastric adenocarcinoma. All right. Identify the pigmentation disorder which becomes erythematous on massage. So can you see this lesion over here? Now, if I massage it, then there is going to be color coming in it. Okay. So is this nevus acromicus, tuberous sclerosis, nevus anemicus, or melasma? Mark in the poll. Okay, so very close poll between nevus acromicus and nevus anemicus, but the answer is nevus acromicus. Okay, it's not the same thing, Mano. Nevus acromicus may, whenever you massage a hypopigmented lesion, it will turn erythematous. On the other hand, nevus anemicus may, there is no hemoglobin only to come there, ऐसे सोचो. If there is anemia, there is no hemoglobin only. If there is no hemoglobin, how will it turn red? Okay, so nevus anemicus may, it will not turn erythematous on massage. Clear? So this is your two nevi that you need to know. Other than this nevi, there are also other nevi that you need to know. I don't know if I put the picture of that here. One second, hold on. I think that picture is not there. Anyways, that must be there in the second class. So I'll show you over there. Okay, so all those who have come late, just quickly look at the lesions that we've seen till now. Acne vulgaris, conglobata, this is Pityriasis alba, then vitiligo, then melasma, then P. boldism, Pityriasis versicolor, and acanthosis nigricans, nevus acromicus. Okay, now the next thing is lesions of tuberous sclerosis that they ask in dermat. So tell me the name of each of these lesions that you see in tuberous sclerosis. So what is this hypopigmented patch present on the extremities called as? Ash leaf macule, absolutely correct. This is called as a ash leaf macule. If only a hypopigmented patch is present, macular patch is present, you will call it as ash leaf macule. Now this patch present at the lower back, it's a very specific place where it is present, lower back, and it is velvety. So this is called as Sjagren's patch. Okay. Then over the nose and the malar area, if you are having growth of the sebaceous glands, what is this called as? This is called as adenoma sebaceum. Absolutely correct. And you are having these dark patches present all over the body of this patient. Yes, it looks like in white milk you have brown color coffee. So this is also called as cafe au lait spots. Okay, or cafe au lait lesion. All right, absolutely correct. Okay, now let's move on to our next disorder. So everyone knows pemphigus is an autoimmune blistering disorder. Now the most important question that they ask you in pemphigus is, what is the site affected in pemphigus vulgaris? What is the site affected? Epidermis mat bolo. What layers of epidermis are affected? Okay, so in what are you having over here? If I show you this row of tombstone appearance, can you tell me the two layers of the epidermis that are present over here? You see this row of tombstone appearance in pemphigus, correct? So this looks like many tombstones. So this is nothing but your stratum basale, that is your lowermost layer of the epidermis, and this one above is your stratum spinosum, correct? So there is edema formation, there is collection of fluid and edema formation over here in the suprabasal layer. Suprabasal layer means above the stratum basale. Okay, so this is the most common area that is affected in pemphigus. So what is happening in pemphigus? Nothing, there is only fluid collection, edema collection that is happening in this layer above stratum basale, and that is why the skin becomes very spongy in nature, and that is what you are seeing in pemphigus. Okay, now you have different kinds of pemphigus. The most important question that they ask about pemphigus is, on microscopy you have these special cells that are present. What is the name of these cells, and what is the very important? Yes, acantholytic cells, what are they called? Very good, Vignesh, very good, Sky. So these are called as Zank cells. Okay, these are called as Zank cells. Okay, now what are these Zank cells exactly? So if you see your cells, these are all connected by desmosomes. Remember I told you in the beginning of the class about desmosomes. So desmosomes are nothing but connecting bridges that are present between the cells in the stratum spinosum. So what is happening over here? These desmosomes are breaking up, and this area where the desmosomes are breaking up, you have collection of fluid. Okay, so this entire area becomes large fluid filled and edematous. So this is called as Zank cell. Okay, large edematous cell. All right, very good. Then these are all the types of pemphigus that you have. Usually they will not ask you anything in detail about pemphigus, but there are simple questions that they will ask you. Which is the most common type of pemphigus that is present? So what is the most common type of pemphigus that is present over here? Yes, so it is Pemphigus vulgaris. This is the most common type of pemphigus that is present. Okay. Then what are the, in paraneoplastic pemphigus, what are the cancers that are associated with pemphigus? Yes, you have non-Hodgkin's lymphoma and one more, CLL. Okay. Okay. Another question that they will ask you is, which is the least common type of pemphigus? Anyone? Least common type? Absolutely correct. So your Pemphigus vegetans is the least common type of pemphigus. Okay. All right. Now, very important question. What do they ask you in the exam? Nikolsky sign is seen in which disease? So that's why I put this picture over here. Your Nikolsky sign is seen in Pemphigus vulgaris. Okay. So what happens in Nikolsky sign? Anyone, do you know what happens in Nikolsky sign? If I put pressure on the lesion, what will happen to the pemphigus lesion? If I put pressure, tangential pressure, what will happen? Absolutely correct. You will have a new erosion that is forming or a new lesion that is forming. Okay, so that is called as positive Nikolsky sign. The other name of positive Nikolsky sign is also bulla spread sign. Okay, so by putting tangential pressure on one side of the lesion, I am also causing a newer lesion to form. So the bulla is spreading in nature. Okay, so this is my positive Nikolsky sign. They ask this very specifically, positive Nikolsky sign is present in which disease? So you should be able to answer this. It is seen in Pemphigus vulgaris. Okay. The second thing that they ask is this row of tombstone appearance is seen in which disease? So that also you should know. Then the next thing that they will ask you about Pemphigus is what are the antibodies are produced against which desmogleins? Okay. So can you tell me in Pemphigus vulgaris, which protein is affected, and in Pemphigus foliaceus, which protein is affected? Yes, so in Pemphigus vulgaris, you have desmoglein 1 or 3. In Pemphigus vulgaris, it is desmoglein 3. Okay, so how will you remember this? Just remember foliaceus हम ऐसे लिखते ना V, so V को तुम ऐसे लिख दो V, and V में ऐसे make another line. So this becomes desmoglein 3. Okay, and in Pemphigus foliaceus, what is the protein that is affected? That is your desmoglein 1. Which is more common? Obviously desmoglein 3, because vulgaris is the most common type of Pemphigus. All right. Okay. Now, next question for you guys: which of these is not a pre-malignant lesion? Actinic or sun-induced keratosis, oral leukoplakia, basal cell carcinoma, or submucous fibrosis? Which of these is not a pre-malignant lesion? Read the question carefully and answer this. Guys, this is only half the lecture. Huh? Part 2 of this lecture is after 5 minutes. It means at 4:05 p.m. We have to do STDs and everything in that. Okay, so 38% of you only got this correct. So that's why I told you this is an English language test also, your exam. So your basal cell carcinoma is not pre-malignant, it is already malignant. Okay? So many of y'all may be knowing everything about all 19 subjects, but if you have not read the question carefully, English बराबर से नहीं पढ़ा तो आंसर गलत हो जाएगा. Okay? So this is already a malignant lesion. Okay. Now, can you, oral submucous fibrosis causes squamous cell carcinoma of the mouth. Oral leukoplakia also causes carcinoma of the mouth. Actinic sun-induced keratosis also causes this. Okay. All right. So this is your basal cell carcinoma. Now they say that basal cell carcinoma is the most common type of skin cancer in the world, and the most common site of visit in the head and neck. It is also called as a rodent ulcer. So you can see it over here. So what is the typical kind of question that you will get for rodent ulcer or basal cell carcinoma? They will say that he is a farmer who works full day in the field. So when he's working in the field, there is a lot of sunlight that he is exposed to, correct? Yeah, so he's having this patch in his sun exposed area. Okay, so that is how. Okay, I'll show you pictures of malignant melanoma also, Ranjit, then you'll be able to answer. But your basal cell carcinoma is a very typical one. First of all, present only in the head, face and neck because they are the main sun exposed area. Second, rodent ulcer because it forms a burrow inside. So can you see like a burrow like thing is formed over here? So this is very typical for rodent ulcer or basal cell carcinoma. You cannot go wrong with that. Okay. All right. So these are all the types that we have of basal cell carcinoma: superficial type, nodular, ulcerative, sclerotic, pigmented. ये नहीं पूछेंगे. तुमको क्या पूछेंगे? Which is the most common type of basal cell carcinoma? So out of all of these, which is the most common type of basal cell carcinoma? Most common type out of these 4 types, 1, 2, 3, 4 में से, which is the most common type? Super. Yes, nodular ulcerative is the most common type. Okay. All right. And what is the treatment? Treatment is nothing but excision of the lesion, and you may also require chemotherapy in some cases. Okay. Now another cancer that is associated with the skin. So that is your squamous cell carcinoma. Again, present in sun exposed areas, but this will mainly be present in the neck. And there will be one very specific word that is given: verrucous or warty. Warty lesion or verrucous lesion that is present. Okay, so it's basically something that is friable and it increases in size very easily. Okay, it bleeds easily and it is ulcerative in nature, but the ulceration in that is not deep like a burrow of a rat. And yes, absolutely correct. One very important thing that you get in this, as Tariq has mentioned out, is presence of keratin pearls. Okay, all right. And the last skin related cancer, this is the most important one because they can easily give you this picture and the microscopic picture that it comes with it. So you have primary cutaneous T cell lymphoma. So T cells get increased in number. This is called as mycosis fungoides. So what is the other name of this? This is also called as Sézary syndrome. Okay. So in the exam, they can also give you this word, Sézary syndrome. So you'll see patches that are present all over the body of the patient, especially on the anterior aspect. More than that, they like to give you this microscopic picture with presence of Sézary Luttner cells. Sézary Luttner cells are nothing but CD4 cells. Now your CD4 cells are increasing. Your T lymphocytes, CD4 T lymphocytes are increasing in this. So you have presence of many CD4 cells that are present over here. Okay, and they form small groups which are called as Pityriasis microabscesses. So the most common question that they ask you about mycosis fungoides is they'll just ask you Pityriasis microabscesses. You don't really have to identify it anywhere, but they'll ask you Pityriasis microabscesses are seen in which lesion, okay, or seen in which disease, or they'll ask you Sézary Luttner cells are seen in which disease, and you should be knowing the answer to that. All right. Okay. What is the treatment for this? Treatment again is radiation. And this is a very aggressive cancer. So this can lead to malignant transformation of the cells and spread of the cells everywhere. Okay. All right. So quickly come back in 5 minutes. 4-5 p.m. we'll be doing the rest half of dermatology. I'll see if that works out for us or not to do continuous 2 classes. But we have to finish our mission, that is short subject should be completed in 1 week. Okay. So all these are the pictures that we've already discussed. You guys can go through it, and I will come back to you at 4-5 p.m. and we'll be discussing the rest of it. All right. Thank you. See you at 4-5 p.m. Bye bye.